Hello, Jeff Fishel, LeFlore County EMS, Levi Townsend, LeFlore County EMS, and we are just going to film a video here of our RSI procedure step-by-step here at LeFlore County EMS for our upcoming CE, and for anybody to reference in the future if they need to look back on it and restudy the process. So we all know the indications for an RSI. If not, we will cover them further in the CE. We just wanted to show you a video presentation of the actual procedure. So we have our patient here. Levi has recognized the fact that the patient's respiratory distress. He's decided that he's going to put a number breather on the patient while he further assesses the patient. Alright, so high flow O2, the patient does have a respiratory drive at this time. Levi has now decided that, fast forward, he's gone through his complete assessment and diagnostics here, that the patient does need to be RSI'd. Maybe that meant that Levi had moved to CPAP and that was unsuccessful, or the condition is not a condition that you would typically CPAP. Whatever the case may be, we are now at the point of RSI. So we are going to go step through the RSI procedure the way that Dr. Brott wants us to do it. So Levi already has a number breather on this patient. He is going to also place a nasal cannula. And if you're wondering, if we're putting a nasal cannula on, why aren't we using a end tidal? We know this is showing up. The reason being is on an end tidal, these nasal prongs don't actually provide any oxygen. If you look real close, the travel of the O2 tubing goes right here. And all it does is essentially spray oxygen out a bunch of these little teeny holes up towards the nostrils, whereas on a nasal cannula, these things would actually be where the oxygen's coming out of. So in this case, we definitely want to be using a nasal cannula because it's directing O2 directly out of the nasal prongs into the nasopharynx. Alright, so Levi has now got nasal cannula on the patient. He's got the nasal cannula at 6. He's got the non-breather up to its rate, 10, 15. IV has been established. We have decided that we need to now ventilate for the patient. So IV has been established. Levi is going to give ketamine, rocuronium. So that has been given. I am Levi's EMT partner, and so he has given that, so obviously the respiratory drive on this patient is gone. We would insert an OPA. This OPA that we have here is obviously way too big, so we are going to verbalize the fact that that is inserted. I'm going to bag. Levi is going to bump that nasal cannula up to 15. I'm going to bag with a good CE clamp as Levi's setting up for intubation. So we bump that nasal cannula up to 15. It causes no damage or harm to the nares, but what it does is we are filling the patient's airway with high concentration of oxygen because we are trying to pre-oxygenate this patient the best we can before an intubation attempt. What we want is 93% and above for a few minutes before we even attempt an intubation. There's too many times that healthcare providers, whether it be in the hospital or outside the hospital, will intubate a patient with a really low O2 sat without proper pre-oxygenation, and the patient will go into cardiac arrest during the process. Or maybe it's a real bad head injury, and we'll attempt to intubate the person and we'll let the O2 saturations, and I don't mean here at LeFlore County, I mean healthcare nationwide, we'll let the O2 sats get down to 70s, 80s. Well, the studies have shown that you do that and you just increase their mortality rate or morbidity rate by 50%. And that's obviously not what we're here to do. So Levi has got his King Vision, he's checked it, it works. He's got his tube, he already checked the cuff on that, there's no holes. And we've already used this a couple times, so that tube is, the channel for the tube is lubricated. He's already put the securing device behind the patient's head. Levi likes the bougie, so he's going to use the bougie and the King Vision. Levi says, I have 100% intubation rate, and I aim to keep it that way. First time. Let's see. He's got his intubated end tidal close by, and he would never attempt intubation without his trusty suction. So when Levi is ready, he's going to tell me, and I'm going to move and take the OPA out.
All right, I'm ready.
Take the OPA out. We're going to leave the nasal cannula in place. So he's suctioning first. No matter what, he's going to suction every single airway he encounters, because the last thing he wants to do is put that video laryngoscope down into a bunch of blood or vomit. Alright, so now he's going in for his intubation procedure. He's using the suction device to help get the tongue out of the way and make sure that when the King Vision goes in, it's nice and simple. Remember, this is not a displacing device. You're not trying to move tissue out of the way. You're simply looking around the patient's airway. He's got a really good view of the cords right now. He's inserted the bougie through the cords. Now he's going to follow that up with the tube. He's going to insert the tube just a little bit further. Notice that he's left the suction device in there, because Levi knows that if this patient starts vomiting again while he's intubating, or blood starts pulling up while he's intubating, that he can continue to suction the airway and not get it full of vomit or blood. Alright, so he's passed it through the tube. Put on his end tidal, or he's passing through the cord, sorry. Now we're going to begin our confirmation processes. Obviously, capnography and end tidal are most important. Also, absent epigastric sounds, positive breath sounds, misting in the tube. The biggest indicator was that we saw it pass through the cords. So he can turn that off now. We can remove the suction device. If we need to, we will put soft catheter suction down the tube. He's going to insert, he's never going to let go of this tube. This is his tube, and he wants it to make sure it maintains. He's going to secure it. And then we don't have one out on the table in front of us, but when Levi's all done here, securing the tube in place, we're going to drop an NG tube. We encourage you dropping an NG tube anytime a BVM was used, or anytime you intubate, really. Simple procedure. Helps decrease gastric distension, helps decrease the chances of vomit in the airway. Overall good practice. Alright, so this is the procedure that Dr. Brott, your medical director, wants to see for RSI. In summary, proper oxygenation before intubation, proper preparation before intubation. That includes the fact that you are never going to intubate without suction on and present and in use. Use the device that gives you the best chance for success the first time, every time. And be prepared for continued sedation and paralytics after you've intubated. And that's it.